shooting free throws, three-pointers, but I don't have that video up and going. I forgot to point out that when Marilyn Summerford was here from Smithville, not only does she know Joe Burrow's mom and daddy, she knows his grandmama and granddaddy and his great-grandmama and his great-granddaddy. I neglected to tell the committee that. Mr. Secretary, call the roll.
Sir.
Your roll. Your roll.
Bryan, Polk, Blackwell, Blunt, Kaufman, DeBar, Doty, Fillingane, Frazier, Harkins, Hobson, Horn, Jackson, Johnson, McMahon, Parker, Parks, Wiggins, Witherspoon.
Thank you. The first item on the agenda is House Bill 708. As I explained to the committee yesterday, a group of members of the committee sat down and listened to the people who have interest in this bill, and basically their recommendation was that we pass the bill. I have one suggestion to make later on, but I would recognize Senator Parks, who I believe is going to explain the bill to the committee.
Thank you, Mr. Chairman. First, let me start by saying that this is not just a Mississippi issue. This is an issue that is occurring across this nation, and as we walk through these steps and what this bill will do, we'll talk a little bit about and see how many states that have already taken action on a majority of these steps. So I'd like to do it by points, starting out with what the bill does. It prohibits the PBMs from requiring stricter or more stringent accreditation or reaccreditation requirements than a board of pharmacy. Prohibits from steering patients to pharmacies that financial interest in a common ownership. It requires PBMs to reimburse pharmacies in a 7-day rather than a 15-day. Prohibits PBMs from having the ability to retroactively claw back a pharmacy's reimbursement. Requires the PBM to reimburse the independent and the retailer pharmacies the same as they reimburse the affiliate pharmacies. The Mississippi Board of Pharmacy will need to collect PBM's proprietary information to ensure PBMs are following the law. It also requires the PBM to create a maximum allowable cost transparency list. And I'm happy to answer any questions, but that is the 7 points that what this bill does. Are there any questions?
Are there questions? One suggestion that had been made, which I thought had some merit, was to change the effective date to January the 1st for this reason. Generally speaking, we're out of session at this point, so we're getting very close to the July 1st effective date. The bill would make a number of changes to existing contracts and practices. Various players need time to sort of adjust to the new law, and I don't think it does that much harm to the bill to have the effective date be January the 1st. I've spoken to representatives of the pharmacists. Although I think they would prefer an effective date of January 1st, 2000, basically say that the civilization will not crumble if the effective date is January 1st. I've discussed this with Senator Polk and some members of the group that met with them. I know that one of the concerns that was relayed to me was that we didn't want to bog this down and continue debate on the bill. I've spoken to the House Chairman, and he tells me that if what we do is send this bill with an effective date of January the 1st, he'll move to concur, and that will resolve any further debate on the bill. So, having said that, if there's a motion to amend the bill to change the effective date to first. I'll recognize that motion and ask the committee if you want to debate this or vote on it. All in favor of the amendment say aye. Opposed, no. The ayes appear to have it. The ayes have it. Would there be a motion, title sufficient to pass as amended? Yes. You understand the motion? Are you ready to vote? All in favor say aye. Opposed, no. The ayes appear to have it. The ayes have it. I want to thank those of you who met with the group yesterday and the members of the committee for your attention to all this. We have with us today Bob Anderson, who's the new Executive Director of the Department of Human Services. We'll be voting on his confirmation later in the session. We've got to get him investigating first. But I'll tell you one thing. I don't ever want to be nominated for anything that involves a peer committee investigation. But I believe we're fortunate to have Mr. Anderson in this position. I think this is one time we got a round peg in a round hole, so that's always good, good to do. I've not asked Mr. Anderson, and I would really prefer that we not dwell on the various misappropriations of funds that have taken place. That's all going to work itself out. There's time to deal with that later. But what I've asked Mr. Anderson to do is simply come explain to us what the Department of Human Services does with a particular emphasis on the federal funds that they get and for what purposes. As someone explained it to me, apart from the fact that they either were or were not actually getting presentations by retired athletes that they asked for, what possessed them to think that a good use of the taxpayers' money would be to employ retired athletes to make presentations in the first place? And so I would like to look at the substance of how the various federal funds have been spent and where Mr. Anderson plans to go in the future. And I know that you have information in your slides, and I'm told there's a slideshow on this magic screen that we have. So, Mr. Anderson, thank you for coming over. Thank you for taking this position, and thank you for coming to tell us what it is you do over there. If you want to take questions as you go, that's fine. If you want to wait till the end, just proceed however you'd like to.
Thank you, Mr. Chairman. I appreciate the invitation to be here. You all have in front of you a black folder. On the left side of that, I thought it might be helpful just to give you a little brief summary of what my background is so you'll understand what I've been doing since I finished law school about 33 years ago. Mostly I've been a federal prosecutor. I've also worked with our Attorney General's office and a couple of years with the Division of Medicaid as Chief Integrity Officer. I have to say I think the governor called me because of that experience in federal prosecution and coming behind situations where money had been misspent. That's certainly what I'm looking at pretty regularly. I wanted also to just take as a kind of a point of privilege, if I might, Mr. Chairman, a minute to tell the committee a little bit about myself that those who don't know me, and even some like my friend Senator Hobson here may not know, even though he's a friend, a little bit about my background that I think probably made the decision for me to come to the Department of Human Services an easy decision for me, not so easy for my wife, but easy for me. And one of those things is my personal background. I have, honestly, personal experience with the notion of temporary assistance, which is a large part of the work that the Department of Human Services does. And the reason I have that experience is back in my formative years, when I was about 10 years old, my parents divorced, and my dad did what a lot of divorced dads do. He disappeared. He was not involved in our lives, and my mom was 30 years old and had 6 children and had been a stay-at-home mom since she got married at 16. And at 30 years old, having never worked, she didn't know what she was going to do to support the 6 mouths that she had to feed. So she initially went to what was in those days called the welfare office and applied for aid to families with dependent children, and then applied for food stamps. And the next stop she made was to go to Ingalls Shipbuilding, which was this was in the mid-70s. It was in its height of employment, and she said, give me the highest paying job that you can give me and train me for it as quick as you can. And they said, well, you know, the job that pays the most that we think you could probably train for is called ship fitter, and we don't have any women who do that job. She said, you train me for it, I'll do it. 18 months later, she had learned to be a ship fitter. And if you want to know what a ship fitter is, her job was to carry around 8 hours a day a 16-pound sledgehammer and a tack welder kind of at her shoulder, and she would take 1-inch steel plates and tack weld them onto the hull of ships to make the ships that we built at Ingalls Shipbuilding. And if I tell you that my mom is my hero, I think you'll understand why. But the other thing about that is she looked at that temporary assistance, and we lived in what was then called, we called it then the low-rent housing projects for about 1.5 years. But within 1.5 years, having been trained and gone to work, my mom was able to begin buying a home for the 6 of us and supporting the 6 of us, so that 4 of the 6 of my brothers and sisters and I actually got college degrees. The other 2 are working in professional areas because of the sacrifice that she made. And I say that to you just to say that I have a personal understanding of what this agency is about. It touches people when they're at crucial places in their lives, and it provides for them crucial help in order to get them to a place of hope. And I actually, one of the first things I did when I came on board as a director is I said, folks, we're going to have a new mission statement. And it's right here at the bottom of this first slide. Our job at the Department of Human Services is to offer Mississippians young and old help today to create lasting hope for tomorrow. That's what we're there for. That's what we are all about. And we do that in the context of 7 programmatic divisions. I'm going to talk with each of them, talk with you about each of them very briefly, just to tell you briefly what they do and what the amount of funding is. But let me also be quick to point out that every dollar that we spend, for the most part, at the Department of Human Services is leveraged. By that I mean we pull federal dollars down with every state dollar that we spend. We are awarded most years about $1.4 billion in federal money, and our budget is pretty tiny in comparison. Our state budget's about $69 million, so that's pretty good leverage for that $69 million budget. So we have these 7 divisions: the Division of Early Childhood Care and Development, the Division of Economic Assistance Eligibility, the Division of Workforce Development and Program Partnership Management, the Division of Aging and Adult Services, the Division of Community Services, and the Division of Child Support Enforcement, and lastly, the Division of Youth Services. I think you can understand from looking at just the names of the programmatic areas why we touch Mississippians young and old. We deal with children all the way through elder, senior adults in our state, and we touch them at different times in their lives. Now, talking first about the Division of Early Childhood Care and Development, primarily what we do in that division is we provide child care assistance for recipients of both our temporary assistance to needy families and our supplemental nutrition program, the SNAP program, for parents who are transitioning off of the Tanf program, and for children who are served by our other program that Early Childhood delivers, and that's called the Healthy Families Mississippi program. You see the funding here on the child care side of the ledger, about $92 million in federal funds, and about $6 million in state funds were required to match that 92 million. And we provide child care vouchers, if you will, certificates for parents so that they can go to work and not have to worry about where their children are 8 hours a day or night or whenever they're working, so that they can have child care available to them in order for them to be involved in the workforce. Now, the Healthy Families Mississippi is a home visiting program. It focuses on 14 of the poorest counties in Mississippi, and it serves both pregnant women and mothers with children up to 3 years of age to strengthen their families and also to make sure that their preschoolers are ready to go to school. I have a unique understanding of that. My daughter is an entrepreneur out in Houston, Texas, and she works with preschoolers as part of her business. And her motto is, and I'll recommend it to you, to your children and your grandchildren, read to your preschoolers until your preschoolers can read to you, is her motto. And we're trying to prepare young children to be ready for school through the Healthy Families Mississippi program. And that's about $6 million in just direct federal funding. Now, the biggest portion, if you will, the biggest part of the division, the Department of Human Services, is the Division of Economic Assistance Eligibility. We have we call it EA for short. We have an Economic Assistance Office in all 82 counties. That's where people go to make application both for TANF benefits and for SNAP benefits. The SNAP program is the Supplemental Nutrition Assistance Program, which most of us of my age anyway, remember as the old food stamp program. It was renamed as the SNAP program about 15, 20 years ago, and it delivers monthly benefits directly to low-income families. That is the largest portion of our federal funding as well, Mr. Chairman. About $600 million in federal funds come directly through our agency, and they just pass through our agency, and we then distribute them to needy families, to low-income families. We also have the Emergency Food Assistance Program, known as TFAP, and it supplements the diets of low-income citizens by providing them. This is the old commodity program where people are provided commodity goods and through food pantries. They can go to the food pantry and get food items so their cabinets are not empty. And we've been distributing a lot of food through that program during this COVID time. We receive about $1.6 million in federal funds for the TFAP program each year. Some of the other things that the Division of Economic Assistance Eligibility does, we have what's called the SNAP Ed program, and that is a lot of what we do at the Department of Human Services is providing education to people, because we all know that education enables people to enter the workforce, and that's what our education is designed to, is to prepare people to enter the workforce, to give them either catch them up even with just a GED so they can then begin a job readiness program, or even some community college training for a specific job like a nurse assistant or something like that. We make those opportunities available. And SNAP Ed also is designed to encourage people to make good, healthy food choices. Anybody who looks at health statistics in Mississippi knows that we don't make the best food choices. Even those of us who have had lots of education don't necessarily make the best food choices. And the SNAP Ed program is designed to help people make better choices for what their diets look like. We get about $5.5 million in federal funds through that program. Then we have a separate commodity supplemental food program that, again, is primarily designed to improve the lives of low-income elderly citizens in this case, and they have food that is distributed to them to supplement their diets with healthier, Department of Agriculture food. We get about $1 million in federal funding through the Commodity Supplemental Food program. Now, the next program you probably have heard the most about, I know if you've been reading any headlines lately, you've heard about TANF. TANF is the Temporary Assistance to Needy Families program. It's what we all used to know of as welfare, except in the mid-90s, if you will recall, we changed welfare to a welfare to work idea. And so the TANF program, although it does provide some direct assistance to families, it also is designed in large measure to get people into the workforce. Because if we get people into the workforce, we get them off of their dependence on temporary assistance is the whole idea. So we provide at DHS, well, let me say this first. Congress appropriates us about $86 million a year in TANF funds. We spend about $20 million of that on direct assistance to families. And honestly, it's not a large amount, but every bit helps when you're in the situation that a lot of these families are. Our monthly benefit amount right now is $170 a month. So it's not just a whole lot. Then some of that money is a part of the relationship we have with Child Protection Services. $30 million of that TANF money goes to the Mississippi Department of Child Protection Services in order to carry out the child welfare program, the foster child program, and the child abuse program that is all part of what Child Protection Services is devoted to in protecting children, whether they're in danger in their home or whether their parents are not taking care of them, whatever. All the child welfare work that CPS does is supported by $30 million of TANF funds each year. Then the balance of that, $36 million of that is distributed to sub-grantees for services designed to help families become self-sufficient. In other words, to train families to get off of TANF. And the sub-grantee program is the one you've heard the most about in recent days. And it is administered through a different division. It's actually administered through our Division of Workforce Development and Partnership Management. And that division is in the process, their job is carrying out a collaborative process between county leaders and local workforce directors, employers and community colleges, community-based organizations. They're trying to find partners who will work with us to train future employees, to train families, to train individuals to get them into the workforce. And that is funded by both SNAP, what's called SNAP E&T, the Employment and Training Program, which reimburses actual vocational training providers for training SNAP recipients. We had a very successful program a couple of years ago. KLLM trained, remember the exact number? Anybody know the exact number? 150 employees were trained as truck drivers through KLLM under our SNAP E&T program. Payments are also provided, directly to training providers. The E&T program is funded, some of it is 100% funded, some of it is funded at a 50-50 level, where we fund 50% of it and the partner funds 50% of it. Now, the sub-grants that we award are designed to carry out the Tanf Guidelines. If you go and look at the TANF statute, it has 4 statutory goals or guidelines. And one of those is the first one, providing assistance to needy families. But then the other 3 are where we rely on our sub-grantees the most. ending dependence by either job training or education, reducing out-of-wedlock pregnancies, the idea there being obviously mothers who have children out of wedlock tend to be teenagers, and it's a whole lot harder for them to get into the workforce when they start having children at a young age. And then promoting two-parent families. Now, these are all written into the TANF statute. And promoting two-parent families, obviously, all of us, I think, would agree that families that have two parents in the household, it's much more likely that there's going to be at least one solid breadwinner, and the family will be less likely to be on public assistance like TANF. What we know happened in past years before I arrived on the scene is that a lot of our sub-grant processes were broken. There's just no other way to describe it. They were not functioning, and grants were being awarded without any real guidelines. So the agency made some changes before the governor even asked me to take on this role as executive director. We implemented an RFP process for awarding grants, even though the law doesn't require that. Federal law doesn't require us to use an RFP process, and state law doesn't. But we thought, the agency thought, as an accountability measure, we went to the RFP process, and we also began to do risk assessments for potential sub-grantees to see whether they had the wherewithal before we gave them a grant to actually carry out the work that they had offered to do in their grant proposal. We've added some significant sub-grant requirements, requiring sub-grantees to submit to us general ledgers before they draw down any money. We've required them to have training by the Department of Human Services on both what their expectations were under the federal guidelines and what our expectations were for them as a sub-grantee. You know, you probably have read in the paper a little bit, some folks saying, I didn't realize what I was getting was TANF money. Well, we're requiring the sub-grantees and their lower tier grantees, third tier grantees, to know that the money they're getting is TANF money, so that they know they have to comply with state and federal guidelines for TANF before they get any of the money. We're requiring monthly programmatic reports detailing not only who they serve, but what kind of services they provided. And it sounds, you know, like it would be very logical that we would have been doing that in the past, but as I said, the system was broken and we were not. And just requiring monthly reports is a significant improvement, obviously. And the reports have to, you know, tell us who they're serving so that we can track them. You know, one of the other things that when I first arrived on the scene, I said, look, we need to begin to adopt some performance metrics to look at what our outcomes are. We haven't been tracking our outcomes very well. And so we're in the process as an agency of developing some real performance metrics. But in order to do that, we have to know who our sub-grantees are serving so that we can track them and see if this person who got job training this year was able to get a job and stay in a job next year in order to see what your tax dollars and mine are doing in order to move those folks from a state of crisis to a state of self-sufficiency. Now, one of the other divisions we have is the Division of Aging and Adult Services. This is where we touch senior citizens in the state the most. We have several programs, a lot of them designed around helping them understand and I'll just use the word, the quagmire of Medicare and Medicaid. Because when you get to the stage in life where you need to apply for Medicare and Medicaid, it is a very confusing, complicated process just to figure out, well, do I need Medicare Part A? Do I need B, C, D? Which of the plans are best for me? Where do I sign up for them? When do I sign up for them? If I'm qualified for Medicaid, can I still get Medicare? And all of these things, we help elderly citizens, senior citizens in our state sort that out through our state health insurance assistance program. And one of the other things, we hope that people are able to stay in their homes. You know, most of us want to spend our lives in our homes. We don't want to wind up in one of these long-term care facilities. Even one of the best ones, I think most of us would say, I'd rather be at home than be in a long-term care facility. So the no wrong door system that we have is designed to help senior citizens find care so they can stay in their homes and not have to wind up in long-term care. Not to say that our long-term care systems are bad. You know, they're doing good work. But again, as I said, most of us would prefer to be in our own homes if we could. And sad but true, in their homes, some seniors are the victims of abuse and neglect, and that's why we have the Adult Protective Service in order to do home visits and check on vulnerable persons who have been the subject of abuse or neglect or something I've prosecuted myself, financial exploitation, where somebody comes in and gets hold of their checkbook and starts spending all of their resources. And when the time comes that they may need that long-term care, they don't have the ability to provide for themselves. And we also have an ombudsman program for those folks who are in long-term care. We have an ombudsman, statewide ombudsman, who is an advocate for all of those people who are in long-term care facilities. And we do a lot of work with home-delivered meals. We normally, pre-COVID I should say, before COVID-19 turned everything upside down, we had a lot of congregate meal facilities around the state, adult daycare centers and feeding sites where seniors like to get together and visit with each other. And so we would provide meals for them in those congregate meal sites. But we can't do that right now, so we do a lot of that in home-delivered meals. And throughout the year, some people can't get out of their homes anyway, and so we still deliver meals to their homes. Aging receives about $28 million in federal funding. There's a state match of about $2.3 million, and then administrative costs that we're required to match in order to draw down that money. Next division is the Division of Community Services, and this is what I would say is primarily home-based care or assistance that we provide. We have community block grants, community services block grants, which help people with, you know, things like finding adequate housing or educational scholarships and things like that in order to obtain and retain meaningful employment. Then we have another program I'm really proud of called Liheap, the Low Income Home Energy Assistance Program. As you might imagine, a lot of folks who live in poverty-stricken areas, their homes are not very energy efficient. They don't have a lot of insulation. Some of them don't have heating. Some of them don't have cooling. All those things we can assist them with the federal grant money that we have through the Liheap program. And then we have the Weatherization Assistance Program, which also helps to make those homes more energy efficient. We receive about $47 million in federal funds for community services that are passed directly through to low-income residents. The next division is our Child Support Enforcement Division. That serves children all across the state, and it has been very, very successful in establishing paternity. You know, the first thing you have to do in order to begin to collect child support is to establish paternity for children born out of wedlock. And we have about a 97, 98% success rate. And through the vendor that we use, that you all may be familiar with, Young Williams, does a lot of that work for the Department of Human Services. They collect about $371 million in child support payments each year. And our state is one of the most effective in terms of the level of support that we recover. That division receives about $41 million in federal funds, and there's a 66-34 match for that money. 66% of it is the federal money, and the state has to match it with 34%. Then lastly, our Division of Youth Services, which is split into two different sections, basically. The Community Services section, which is the youth court system that you're all familiar with all across the state. We have youth court services workers who work with all the youth courts all across the state, and we administer the juvenile probation and parole system in all 82 counties. And we provide leadership to the juvenile justice community, and work alongside the Child Protection Service to promote change for youth, for family units, and for communities. And then the institution section, which I kind of think of as the place of last resort for a lot of these troubled juveniles, and that's Oakley Youth Development Center, which also has there's a fully functional school there called Williams School, and there's a medical clinic there as well. And you know, from year to year, we have as many as 100 or more youth who come through there, and we provide full level of services for them, everything from housing to feeding to schooling them to providing for their health care needs while they're at Oakley. And most of our youth service division is dependent almost entirely on the money you appropriate to us as state funds, because about 15.7 million of youth services budget is state funds, and then we receive a small amount of Title I money for operating the school. So that is an overview for you of what the Department of Human Services is all about. I hope that was informative to you. I'm certainly open to your questions at this point, Mr. Chairman.
When you were discussing the Division of Aging and Adult Services, you'd made reference to those who had reached the time of life where it was time to apply for Medicare. I was wondering if there was a more optimistic way to phrase those who had reached that time of life that made it more of an uplifting.
When they reach the opportunity time to take advantage of those benefits. How's that sound?
It sounds better. Thank you very much. It's clearly a very informative and concise explanation of a very broad topic. In listening to your presentation and in talking with you earlier, one of the things that struck me is there are quite a few things that your department does that other people do. And I wonder to what extent there's coordination among the various agencies who have an interest in education or an interest in job training or on and on and on. What's your perspective on that for the time you've been there?
Yes, sir. In the 3 months I've been there, I would say my perspective right now is we cooperate to some extent, certainly with CPS, because they're essentially still part of us, even though they're whatever in not of means. I'm not sure I understand that phrase, but they're in not of, and we obviously touch a lot of the same population as Child Protection Services. We have a very good relationship with the Division of Medicaid. For example, at Oakley, we're in the process of working out a relationship where the youth at Oakley will be covered under Medicaid while they're there, and that will allow us, hopefully, to save some of the state funding that we've been spending on their health care needs. We have a good relationship with the Department of Health, particularly in our child care area. We work real closely with them. In fact, our deputy director for early childhood care and development, we just brought over from the Department of Health. But I would not be telling you the truth if I said we couldn't do more, because we can do a lot more in terms of collaborating, cooperating, and working alongside these agencies. And I think everybody, I have a good many of my senior leadership team here, and they know that one of the goals that I have set for them and for us as an agency is for us to expand that interaction, that collaboration, that cooperation with our sister agencies who are touching a lot of the same population. So we've got some work ahead of us, and we've been talking with Taylor Cheeseman, for example, the interim commissioner over at Child Protection Services, and we'll be talking with some folks again at the Division of Medicaid, and I think there's room for improvement there. But we are working together because we serve a lot of the same community all across the state.
Well, just looking at the numbers in your presentation, it strikes me there's an awful lot of money there. And I know that I guess I'm talking about a long-term proposition and not anything that takes place between now and Sunday. But one of the things I'd like for you to help us with is figuring out how we can better coordinate with everybody across state government, many of whom are dealing with the same issues. I expect we could do better. And your example of Medicaid to pay for people that...
Sure. Well, and I'll tell you another idea that has occurred to me, and you know, I don't want to step on any toes because I know every county that has a county office wants to keep a county office, so I'll say that first and foremost. But Medicaid delivers its eligibility function very well on a regional approach. They have 30 regional offices. There's not a Medicaid office in all 82 counties, but yet I don't think folks have trouble finding a Medicaid office in order to apply for Medicaid benefits. And one of the ideas that we're at least looking at and considering is whether we can maybe begin to talk about making a transition to a more regional approach to at least our eligibility. I'll say this just so you know what a difference it would make. About 880 of our employees are out in the county offices. And so that's the largest portion of our 1,500 or so employees in the division. But that's a dialogue we have to have with the county. We understand that, and with the county directors, and with all of those employees. You know, we've got a lot of employees who have spent a lot of time, a lot of their work lives as a part of DHS, and we want to, you know, make an opportunity for them to continue to do that if we can. But I am every day thinking and talking with my team about ways that we can be leaner and be more efficient in what we're doing with the funds, because you know, as I said when I started, we leverage every dollar that we get, and if we spend less for administrative costs, then we can spread those leverage dollars even further, and that's certainly a goal of mine.
Well, another question would be the possibility of having one office for y'all and for Medicaid and perhaps for other entities as well. This is not my area of expertise.
That is certainly a possible approach. I mean, again, we're touching the same population, so to speak, for Medicaid, for our TANF and SNAP program, probably to some extent for Child Protection Services. You know, we're you know, a lot of our county offices, we have a DHS side and a CPS side, and there's room for some consolidation there too, because there's a lot of duplication between the two agencies.
Thank you. I'm sure members of the committee have questions. Senator Blackwell.
Thank you, Mr. Chairman. Mr. Anderson, appreciate you being here. We're sorry to lose you from the Medicaid, but happy you're over at Human Services. look forward to working with you.
Sir.
And, you may not be able to answer this, but it's on your sub-grantees for service designed to help families to become self-sufficient. Talking about we spend $36 million in that. Do you have any statistics yet on the number of folks that we're training and who have been successfully removed from the TANF program?
Senator, I wish I did. I do not have those statistics at hand, and that's one of the things that's been frustrating to me coming into this job is being able to know for myself and certainly be able to tell the public what has been what are the bang for the buck, so to speak. What are we getting for the money we're spending? There was simply not the leadership prior to my arrival, and I won't say this with respect to Chris Freeze, my immediate predecessor, but certainly John Davis was not, he was not demanding of those sub-grantees anything much in the way of telling the department what they're doing with those millions of dollars that we were giving them. We had some anecdotal stories, and I've seen some videos that were made of, individual stories here and there, but in terms of hard numbers to say we provided education for 1,200, 2,000, 5,000 people, and 500 of those got jobs, I can't tell you that, Senator. I cannot.
I would trust maybe next year you'll be able to provide us with some statistics along those lines and others that you'd mentioned as far as tracking and the success of helping people rise out of poverty and be self-sufficient on their own.
Senator Parker?
Thank you, Mr. Chairman. I think we've gotten into some very good points here, and I just want to ask this question to start where I'm going to leave with this, but you've mentioned in here workforce development that as one of the areas you kind of touch. Who is your state go-to person on workforce development right now?
Yeah, her name is Sandra Giddy. She's been directing that division for about 20 years, I guess. She's been at the department about 32 years. Unfortunately, come June 30th, she'll be leaving our agency, but she has had an assistant, a deputy named Kim Smith, who's been shadowing her for about a year, and I think we've actually named Kim as the new division director, and she'll be stepping into that role.
So she serves as that role at DHS right now, correct?
That's correct.
But when when we start talking about going into these interagencies and these other transfers and things, so when you're looking to kind of network or connect with the other agencies that deal with workforce development in our state, who is that go-to person for you, or do you have one that just comes to mind for you?
Well, in other agencies, obviously we work with the Department of Employment Security. They're a partner of ours regularly. I'm part of the board of the State Workforce Investment Board, and they're a partner with us and looking at workforce needs across the state. So Patrick Sullivan being the go-to person there. So.
Well, the problem we've identified from a workforce standpoint is much like you. We have all this federal money that comes in, and we have all these different pots that it goes into, and we have tremendous amounts of duplication of services. We know that throughout there, and we don't really seem to have that kind of go-to person for the answers on things.
Right.
And you mentioned SWIB, and the challenge sometimes with SWIB is that SWIB has 45 members on the board, and SWIB is challenged to be meeting the qualifications and the mandates of WIOA,
right,
more so than they are to be managing the day in, day out tasks that are imparted on workforce in the state. So one thing this body's been looking at during this session is trying to have you more of a go-to source for workforce who can kind of coordinate and kind of be that point of reference. And to Senator Bryan's point, sometimes when you look at government and you say you need another point of reference, and you say you might need another person there, you hear that call of, we'll be growing government. But it seems to me, at least in this case, as you've laid this out today, that we certainly have a lot of money in these pots. We have a lot of holes that can open in it, and we don't necessarily have the oversight at every level that allows that to be watched on a daily basis. But I look forward to working with you in looking at your background and what you've done. I think you're perfect to kind of move into this role, and I look forward to seeing you later in the confirmation process.
Thank you, Senator. Let me say this in regard to accountability, and I didn't mention this earlier. One of the first things I also did when I arrived at the Department of Human Services was looked around and said, where's our compliance officer? Nobody could tell me because we didn't have one. So I created, May 1st, a Office of Compliance. I brought Sandra Griffith over from the Division of Medicaid. She had also worked at UMMC and at Blue Cross and Blue Shield in regulatory and compliance matters. And our Office of Compliance is committed to doing just what you're talking about, coordinating all of the work we do across the entire agency and making sure that they all are working together, that what community services does, if it impacts workforce development, they know about what each of them are doing. If youth services does something that impacts child support enforcement, that they know about it. And to the point where we've even made the new compliance office will be the clearinghouse, for example, for all of our state plans, for all of our internal operating procedures, for everything we do will flow through in order to be accountable and to be coordinated across the entire department.
That is refreshing to hear in light of what we heard coming into this session. So,
Yes, sir.
thank you.
Thank you. We're getting short of time, but Senator Horn, I think, had a question.
Thank you, Mr. Chairman. Mr. Anderson, likewise, I applaud your willingness to take on this new role. We had a good meeting a couple of weeks ago, but want to follow up with a couple of questions. When the bombshell hit and we had all of this stuff revealed about theft, fraud, embezzlement, etc., a lot of subgrantees were impacted by the arresting, literally, of the process for a lot of the granting process at DHS. A lot of them suffered. They were innocent bystanders in what was going on. How have you gotten that process back out? And do you anticipate having to send money back to Washington, D.C. at the end of this fiscal year?
Okay. Two things, Senator, that we've done, because we wanted to know what our subgrantees were doing, both in terms of all the revelations we heard in February and also what they've been doing during this COVID pandemic. We recently surveyed all our subgrantees, and we're in the process of compiling their responses to see what they've been able to do during this year up to now. And secondly, we're in the process of preparing a new RFP in order to put some money that was originally targeted, for example, for a couple of subgrantees that you've all read about, who are no longer subgrantees with this agency, putting that money back out available for RFPs for additional subgrants. And we hope to announce that RFP by July 1st at the latest. It'll be available, the funds will be available beginning October 1st. And if we get good response, I don't anticipate we'll be giving any money back. But part of what we've got to look at is what people have been able to do. I know a lot of our subgrantees haven't drawn any money, even if their subgrant was not affected by all of the revelations of embezzlement and everything else. They haven't drawn any money on their subgrants since March because they haven't been able to deliver any services. And we're trying to get them to tell us, what have you been doing in the meantime? What can we do? And where do we need to go from here in terms of the subgrant money that was awarded to you? Are you going to be able to use it? If not, do you want to bid again on something else? But we're trying to find out as quickly as we can what folks have been able to do and what they're interested in doing going forward to avoid exactly what you're talking about. We don't want to have to send any money back, because every dollar that is sent to Mississippi, we want it to be spent in Mississippi.
And did you say July 1st or August 1st for the RFP?
July 1st, and we may get it out sooner. We're working on it. If we can get it out this month, we'll get it out this month. But
And that's after-school programs, workforce development, and family dynamics. Is that correct?
it'll be all those buckets, yes, that we did back in September and October of last year.
And one other question. Career Pathways is a program that at one time was being promoted by the U.S. Department of Health and Human Services to get people who are on SNAP program or who are on TANF or what have you to go into career pathways and have the kinds of support services, whether it's child care, transportation, stipends to help supplement the folks in the programs, tuition, to make sure that they were going and getting training for jobs that will really get them off of welfare and keep them off of welfare. What are you all doing right now as it relates to career pathways or whatever else you want to call it that will encourage our folks in Mississippi to find independence?
Yes, sir. I think probably what I can tell you that we're doing the most is we're trying to get away from what was the pattern in years past where every division kind of operated. You all have heard the phrase silos. They all did their own thing separately. They didn't even look across the hall to see what the other division right next door was doing. And part of my instructions to the division directors and to the deputy directors who work at the department is let's put all of our work together. Let's coordinate all of our work. It doesn't help a bit if we give somebody child care assistance and they don't have a job to go to. And by the same token, if we place somebody in a job but they don't have child care, well, they can't take the job. And I understand all of those. And so we're focused on coordinating and collaborating across. You would think we would have already been doing that. And we were to some extent. But I like what my compliance officer says. She comes to every issue not saying, how have we always done this, but how can we do it better? And that's my approach as well. How can we do what we're doing better? And we're moving in that direction.
Thank you, Mr. Anderson. Thank you, Mr. Chairman.
We have time for one more questioner, Senator Wiggins.
Thank you, Mr. Chairman. First of all, Bob, thank you for your story. I think that's, I did not know that, and that says a lot about you and your family and all that. So along the same lines, I think 4 years ago, we passed, the legislature did, what was referred to as the 90-10 bill. It was House Bill something or other, by a directive from the feds to utilize money for the agencies to work across each other, the computer systems and all of that. Medicaid was part of that, but actually I think it was DHS, and I remember your predecessor weighed in on the bill. So that was a directive from the feds. So since that time, personally, I've not heard anything, and my impression was that, or is, that it has stalled for whatever reason, and that cooperation is not ongoing, and we passed that legislation so that DHS and Medicaid and CPS and all of them can all use the same computer system, the same database, the same whatever, because they're all all the people are connected in some way of that. So what is the status on that, and where are we headed with it?
Well, what I can tell you, what I know about the status of that is there was an RFP issued, I think it was last fall, for something called the Fraud and Abuse Module, which was part of that act. And that is devoted to, and it's a cooperative effort between DHS, Medicaid, and CPS in order to basically match our eligibility findings against each other. So that Fraud and Abuse Module is an IT product. It's a software as a service kind of model. I don't know whether it's operational right now, Senator. I couldn't tell you for sure. I know the RFP was issued back in the fall, and I think the award was made maybe in February or March. So whether it's become operational in the light of COVID, I couldn't tell you. But I know when I was still at Medicaid, The IT department there was regularly meeting with Jacob Black, who was with DHS at that time, and there is a move going forward. Now, where we are right now today, I can't tell you for sure, but I know that the FAM, as it's called, the Fraud and Abuse Module, has moved forward. So.
Thanks. Yeah, it was reminding me that it was called the HOPE Act,
Yes,
and so that was 4 years ago, and it's taken 4 years to get an RFP on that. So can you find out where that is? And there's different things within that HOPE Act to facilitate the eligibility and all that, which goes to what the chairman's saying about working across these lines. So I guess in an abundance of time, I'd ask y'all to please work on that, and let's get that moving.
Yes, sir. I will say this, that Drew Snyder and I have a very good relationship. I worked for him for a couple of years as his Chief Integrity Officer, and we have a good working relationship, and I'll follow up with him and get back to you, report back to you on where we are with the HOPE Act in regard to the FAM and anything else that's been done.
Thank you.
Thank you, sir.
Thank you. Thank you, Mr. Anderson. We appreciate your coming to visit with us, and we'll hear from you again after we've had the peer committee investigate you.
Thank you, Mr. Chairman.
Thank you.
Appreciate it.
I have asked the State Health Officer, Dr. Thomas Dobbs, to come over to the committee. And Dr. Dobbs, you can come on up if you'd like to discuss the particular developments in our concern about the coronavirus, the COVID-19, in particular as regards to the usage of intensive care units in this part of the state. So, Dr. Dobbs, thank you.
And I won't keep you guys too long, but there's a scenario I know that I've been in close communications with Senator Bryan and others to make sure we're regularly aware of what's going on. So one of the scenarios that has kind of come to light as we're going through this is we were having some real utilization issues with our hospitals and our ICU capacity. And over the past few weekends, actually 2 weekends in a row, we've had emergency requests from hospitals that they don't have ventilators, or they don't have ICU rooms, or they can't transfer ICU patients because their capacity is sort of at a limit. If you look at statewide capacity for intensive care services, there is some capacity, but it's very lumpy. You know, we have maybe 16 beds open in Corinth, but none on the coast. We can't send them obviously easily from the coast up to North Mississippi. So what we've identified are a couple of issues. We do have some ongoing coronavirus transmission that is stressing our capacity. This far into the summer, not only are we seeing ongoing ICU utilization and ventilators, but we are seeing, in some areas especially, slight uptrends in the number of folks. You can see that, we're at about 455 COVID patients, 96 on ventilators, 141 in intensive care units. One of the real challenges with people with coronavirus is once they get very sick, they will occupy an ICU bed for weeks and weeks at a time. But it's a good investment because if they get the right care, their survival rate actually is probably going to be closer to 80% than the sort of horrible things we saw before. So the people who end up on ventilators, it's a worthwhile investment, and those folks can go home and get better. The other situation that's really kind of pushing this is as we have sort of opened back up the medical economy, and people are doing elective things, and people are coming back to the ERs and getting some medical attention that had been delayed, we're seeing really, like on the coast, we have in some places no ICU patients with coronavirus, but they have no ICU beds because they're full with non-coronavirus people. And not that that's a coronavirus's fault, except for the backlog, but it still is a situation that we're concerned about, especially as we look into the hurricane. And if we had to depopulate a hospital or a few hospitals on the coast, it would really stress the system. And mostly I wanted just to make you all aware of that. We are working on it. We have several different strategies to try to help sort of load balance the system, try to decompress, but also look at options that maybe expand our capacity. One of the things, though, that really worries us is we know how, and I think, Van, are you there? I want to say this. We know that when we restricted elective procedures and surgeries, that time period was very effective in emptying the hospitals out to make sure that we could take care of coronavirus. And we're really worried that we're going to stress the systems out so much that we're going to have to look at that as a real option. And we do understand the financial pain that the health system feels, because it's those elective procedures actually that are the profit margin, just to be honest about it. So the other part of this equation is, if we didn't have these coronavirus patients in the hospital, we would be able to have that excess capacity. But what we're seeing, if you look at the next graphic, we've seen a shift in our patients being younger and younger. And what we think this means, not only by numbers, but also too anecdotally, is that people are going out in violation of the current executive order and socializing in mass gatherings in a way that increases transmission. The outbreaks that we're seeing now are from crawfish boils, from block parties, from bunco games, from funerals. And, you know, they're innocent things on a good day, but in the context of coronavirus, it's a real challenge. And so I would like to communicate with you guys so that you can take it back to your constituents that, yes, we want to get back to baseball tournaments. Yes, we want to do the stuff we used to do, but there are certain inherent dangers in that. And part of the dangers are, even if we have these really strict guidelines, and we're trying to be very safe and let people get back to some degree of normal, such as like with youth sports, but especially with things that have emotional components like church or funerals or graduation ceremonies, people can't keep from touching each other. They just can't. They cannot help themselves. And we've seen a lot of outbreaks going on. So it's going to be something we're going to struggle with. Right now, the executive order says there's a maximum indoor meeting of 20 or 50 if you can properly social distance. Outdoors, it's 50 or 100 if you can properly social distance. Those are pretty good numbers for transmission, but they're not very big. And we're seeing, I went by an indoor restaurant, and they certainly weren't complying with the restaurant guidelines. So we're seeing a lot of that. We're going to try to work with our licensure folks to help make sure that they understand the implications if they're not complying. So there's a lot of that in the mix, and I think it's really important for you guys, as the Public Health Committee, to be aware of it, and we're going to be trying to address it from multiple angles. And I think, Chairman, I like your mask. These, we got a bunch of them out front, or we're going to have some for you. These are actually washable, easier to breathe through, and they actually are lined interiorly with copper as an anti-germicidal component. So we got more of these came from if y'all want them. We got about 2 million actually. So, all right. And that's all I have, sir.
Where do
Thank
we
you.
find those?
These were CDC, HHS delivered masks.
I mean, where do we individually find them?
They should be, we had a bunch here for you. We're going to start handing them out to your community. We're going to push a whole bunch. We've already sent like almost 3 million masks out to communities in Mississippi. So for your counties, your local emergency management agency will be the point person for that, and we will send them to them, and they'll get them to your community.
I have read there are those who are looking at the national figures and the decline in the number of cases and the number of deaths and on and on. And those who look more carefully say that one of the things that's going on is that New York City is so dramatically going down, that in and of itself disguises what's going on in other areas of the nation where there is an increase. And so you look at the national figures, and that's not a complete picture of what's happening. I'm gathering from what you're telling us today that's also true in the state of Mississippi, that the virus is more active in some places than others.
Yes, sir, and certainly we've seen that, and we're also seeing that everywhere is vulnerable where it's going to pop up. Some of these places we've had a lot of cases are very rural too, and we hadn't seen that before. And been making a lot of visits, Wayne County, Jones County, places we're really worried about. Forest is kicking up pretty hard. as number of cases. But we'll be working diligently to try to help get the message out and intervene as appropriate.
Other than being aware of the situation with ICU units, and other than restricting elective surgeries, I'm not aware that that would necessarily lead to ICU usage, but maybe it does. What can be done if we are having this potential shortage?
The first and the best thing would be to prevent cases. And one of the things that I've been meeting with people locally, and I think there's a little, in my mind, there's a bit of a fallacy that social distancing is bad for business. Quite the contrary, I think social distancing is essential for business. If we don't want to have to shut it down, if we want to find a way to find a new economy that works with people wearing a mask and just being a little bit further apart, I think that that's something we have to do. And then businesses are calling me from communities saying, you've got to do something about my county. And then when I go talk to the county supervisors or the city folks, they say there's some resistance because they're worried about hurting business. So I think there's a mismatch. I think most business folks understand the risks that we're undergoing. We don't want to go backwards. I'm afraid that the gains that we've made might be lost if we're not really diligent. And it's not the stuff that hurts business. Business is not getting hurt if you close down a block party or if people don't play cards. So anyway, that's the one part of it. The other part of it is that we're going to work on us trying to do more formalization with the system of care for transferring patients, load balancing, making sure we get people to nursing homes quickly, making sure we get people to these convalescent hospitals so that we can decompress the busier hospitals, and then looking at how do we expand our capacity within hospitals and then beyond if we need to.
Members have questions? Senator Harkins.
Thank you, Mr. Chairman. Dr. Dobbs, thank you for your work over the past couple of months. On the graph that I'm looking at that has the chart with the number of patients, do y'all have, or number of cases that are positive, do y'all have any chart that can overlay with this with the number of tests that are being performed? Because I know at the beginning we didn't have a lot of tests. Now we have a lot of tests available. So, you know, if you have 456 cases, how many tests were done over that time period to get 455 or 450, 55 cases?
And this is cases in hospitals. So this is going to be people who are sick enough to get hospitalized on this one. But we do have the data, but not in that sort of graphic format. So I understand your question because we're testing a lot more people and we're finding more people. That is absolutely true. But the metrics of hospitalization and ICU use are pretty solid as like a gold standard indicator. But we're working to get that information that'll be in a better format. One of the challenges is we've shifted our testing strategy so much that the number of tests that we do, like when we've done all the nursing home patients, we test all the nursing home patients over 2 weeks, our percent positive went from like 9% to like 3%. And so we're not picking up as many cases, and so it looks like we're doing great, and there's less people who are infected, but it's because we shifted our strategy into an intrinsically lower risk population than someone who's symptomatic or is exposed at whatever venue. So that's something that we'll try to get in a format that's usable. And then we have some other graphics I think that you'll find usable too. Yes, sir.
Okay, and then my other question or comment would be when the chairman asked, what do we do on, shutting down elective surgeries? Is there not a shift maybe to ambulatory clinics at actually surgery centers that are capable of doing these elective surgeries that aren't housing? I mean, if the people check in okay, they don't have a temperature, they haven't been around anybody, would you not be able to allow for more of these type of surgical centers to do that type of work?
That's the perfect question that we're asking right now. One of the things that we're looking at is I've got some of my epidemiologists looking at what types of surgeries lead to hospitalization, what type of surgeries lead to ICU stays, such that before, we kind of used a sledgehammer, but if we go into it, we'd rather be a little bit more surgical, excuse the pun, and then, because like some of the things that, and my hospital people out there, I hear y'all cringing, but like orthopedic surgeries have a high percentage of people go to the ICU when you don't anticipate it. But some of the other stuff, obviously cataracts and some other stuff, GI procedures, outpatient, we would certainly not want to think about diminishing low-risk outpatient procedures.
Thank you.
Thanks, sir.
Senator McMahon.
Dr. Dobbs, I wanted to personally thank you for your responsiveness and service to the state of Mississippi and to our citizens during this event. I know there are several times we've spoken very late at night or early in the morning after speaking late that night, so I know you put in a lot of time. I'm going to ask you a question. It's a friendly question, but if I heard you correctly, you're talking about possibly stopping elective surgeries again?
Not now. We're war gaming it for the future. We think we can sort of mix and match right now, but there's enough tension in the system that if we don't have a plan a better plan going forward, it's a thing that may happen in the future, and we're meeting with other partners, and we've got a group of people to meet with to find those options. But the thing that's really most worrisome is I'm not scared right now. I'm terrified about August. And if we're tight right now in the slow time, because now is the slow time, what are we going to do when it gets heavy? And so this is mostly preparation work, although if we're not careful, if there's a hurricane or if maybe there's a surge from Memorial Day, then there may be some necessary conversations about temporary stopping some of these things to make space.
What's the capacity of this state for COVID beds at this time?
We have legitimately probably several hundred ICU beds.
Well, I know there's a difference between an ICU bed and a COVID bed.
Yes, sir.
So I'm asking you directly, not ICU beds, but directly, how many COVID beds do we have in the state of Mississippi at this time?
Do you mean like how many could we supply if we had to?
That's correct.
We could probably supply a dozen additional ICU beds, and we could probably supply probably a couple hundred additional floor beds, med-surg beds.
But what is that number? Is it 1,000? Is it 500? What's our capacity currently?
We do a daily census of how many beds are available, and actually I wish I had it with me. I could tell you, and actually we can talk later if you want to, and I can go over it specifically, but it's several hundred beds that are open, and then probably quite a few ICU beds. The problem that we're finding is a lot of the ICU beds are like in Marion County.
Yes, sir.
Or other places that, maybe like UMC's putting them in the PICU, the pediatric ICU. So there's some variable quality we're having to look at, and we don't want to endanger people by putting them in suboptimal environments.
This is a friendly question. I'm not trying to trap you. I don't want you to feel that way, but like I know there's some small hospitals that I've toured where they took all 8 or 16 ICU beds and converted everything to COVID because they weren't doing elective surgeries. But the point of I hate to use the word locking down the economy, but that's what we did based on the healthcare professionals' recommendations. But we wanted to try to give the hospitals time to put the assets in place, whether it be beds or it was ventilators or PPE to service the community. But what's the point of saving the hospitals that if we can't do elective surgeries and we put them out of business financially?
I agree, sir.
So, we've got to be sensitive to that. And when you start having hospitals that have thousands of employees and they're laying off 40%, literally 3,000, 4,000, 5,000 people in the community are being furloughed or losing their jobs. We have to. I know this is already on your mind, but I want you to know it's on my mind and my heart too, because I can't lose my home because I can't pay my mortgage because I'm scared to death to go to work. There's certain inherent risks with going to work. I realize that, but we can't try to manage this crisis and at the same time put our health facilities out of business, especially the small rural ones that are already struggling. Wouldn't you agree?
Yes, sir.
So I appreciate you answering my question, but you've got my cell number. Let's just maybe talk tonight or tomorrow, because I'm curious what I mean, what COVID bed assets we have in place today. And how many of those beds are being used. And I'm sure there are some triggers already in your mind about where let's say we have 1,000 COVID beds. You know, what percentage are you talking, when we get to 100%, then you're talking about doing something, or are there triggers in your mind?
We're trying to work on that to have a more reasoned approach than we had to go through before. And we will take in a lot of input from the experts who run the hospitals to know what that looks like. I mean, the other option is to expand internal capacity, and that's what their crisis standards of care are. But the problem is a lot of the expanded ICU capacity that they have on their books is ORs. And so if we put COVID patients in operating rooms with operating room ventilators, then obviously they're not doing surgeries. So there are intrinsic problems with that model. The other challenge is medical staffing. And certainly at UMC, we've spent a lot of time with those guys, and they're really feeling the crunch. They haven't been able to take people that they would normally want to take because they don't have the beds available. And then they're having real staffing challenges on the clinical side. So again, this is sort of, it's urgent, but it's not like an emergent sort of situation. But it's going to take some attention, and our hospitals are stressed. And I think that, you know, obviously they've been damaged significantly. And as a healthcare person, I used to be a hospital executive, and I had to, you know, look at the numbers and everything. I'm very, very cognizant of the challenges.
Taking my questions, and thank you, Mr. Chairman.
Thanks, sir.
I understand the need for the restrictions on our long-term care facilities. My mother's in a long-term care facility, and I haven't seen her since February, and I am just concerned. You know, seeing your family is important. And what's it going to take for us to get back to a point where we can allow some visitation in our long-term care facilities?
We're looking at that really closely. CMS, you know, who really writes the rules, has come up with some really hard guidelines to opening up ICUs and nursing home visitation. And one of them is basically you have to have 4 weeks of consecutive decreases in countywide transmission of coronavirus. So we've never seen that in most places. I mean, we might have in some places. So we're going to try to find the nuanced situations where we can find the openings for that. But, you know, we just finished all this testing, and so there may be sort of a window where nursing homes that have no cases, you know, and haven't had cases for a little while, we know don't have, you know, active transmission. We might be able to find some pathways for sort of carefully scheduled sort of visitation sort of issues. So it's tough. We have a lot of rules that CMS has put on us from doing it safely. And we actually have a group of people who are working to try to find a way to do that.
I would hope that we could do it maybe, you know, county by county or region by region, and not, I think if we do it as a state as a whole, it would be very difficult.
We'll never do it. Yes,
Yeah.
ma'am. I agree.
Senator Fillingham.
Thank you, Mr. Chairman. Appreciate it. And thank you, Dr. Dobbs. We appreciate your help. And I do appreciate you taking my phone calls. I know we've all probably been bugging you tremendously, but our constituents call and we have to try to get answers. So thank you for doing that. A couple of questions. It looks like some of these hotspot areas, I assume that's what you've listed in your graph here. Of course, some of them, like you said, are the smaller counties, as you could imagine. The larger counties would have large caseloads, but like Covington County and some of the smaller ones, are these the new hotspots for the outbreak of the virus, in your opinion?
Yes, sir. Absolutely. We've seen some sort of dramatic changes in different places, like, you know, Covington's got a bunch. Jones has a lot. So Jones and Wayne are interesting. Neshoba's been up there for a while, but Wayne and Jones have kind of really jumped up. And the thing that's happened is some of these places like, say, Scott County or Leake County, we saw that a lot of those were associated with a combination of long-term care outbreaks and poultry or, you know, processors. And what we've seen the shift is, so Jones County is now 2.5% from poultry folks, and it's mostly just people getting it out and about in the community. Wayne County is like 90% of people just catching it just from being around town. And that's one of the reasons why I'm so really worried about it, because it's not in these little pockets, it's just out and about. And if we think about, like, on average, how many people in Mississippi are actively contagious with coronavirus, that's probably going to be between 1 and 150 at any given time. So within this building, on average, there's probably a couple of people who have coronavirus spreading it every day. And so if you go to a group of people and there's a bunch of folks, there's a good chance that somebody's going to be spreading it every single day. So these simple little things are going to be really important to keep it from spreading.
And the ICU beds in these areas kind of mimic what you're seeing. I mean, you're getting like at South Central in Jones County where you live, or over in Hattiesburg where I live. Are you seeing the number of ICU beds going down because of this?
Yes, sir. A combination of probably the Pine Belt's worse. They have higher burden of coronavirus, and so it's really stressing their ICUs. For the first time in my life, they had to transfer a patient from Laurel to Gulfport because they couldn't get him to Jackson or Hattiesburg. And now, Gulfport's full. So what are we going to do? And we're going to send them to Tupelo? Maybe. I mean, that might be in the cards. So but Covington, the other thing is the expertise. You need to have pulmonary critical care docs where those are, and there's not that many of them, so they're going to be in Hattiesburg. It's going to be, my wife's that one in Laurel and on the coast and Jackson and, that sort of thing.
The other question is, and I know you've mentioned this in previous hearings, but I just ran some quick numbers. It still appears, based on the number of our African American constituents getting this or having a positive outcome here, is much, much higher, almost 2 to 1. It looks like there's about 62% of all the cases in the state are African American, with a percentage of the state of 37% roughly. So it's almost a 2 to 1. What do you attribute that to, and is there something that we can do further than what we've already done to try to help mitigate that?
There's probably several things that are driving that. To begin with, out the gate, the black community was way affected. So they're going to stay ahead just because it's circulating in the black community pretty aggressively. We've identified gaps in testing, and, access to health care is always a big concern. But it does appear now, too, like in the rest of the state, that a lot of it's going to be social stuff, funerals, churches, get-togethers that are driving a lot of it right now, and as the proportions we've seen, the proportion of the bad impact of that also is in the black community, but it doesn't discriminate other than as far as the transmission goes, but it's just already so much worse in the black community.
And then my final question would be, are you seeing any evidence that if you've already had the virus and you've successfully come through it, or if you have antibodies, does that provide any immunity, or can people get it a second time?
I think, and although it's still up for debate, based on a lot of different elements of research, that you probably are, almost certainly most people are immune for now. If the virus mutates by the winter, that could change, kind of like flu. It's not quite as mutagenic as flu, but there is some potential there. So probably yes, for now. The problem is we've had, I don't know, like how many, like 9,000 people get the blood test in Mississippi, and like 2% have antibodies. So to get herd immunity, we need about 70, 80% of people to have immunity. So all we have to do is go through this about 35 or 40 more times, and we'll be good. Thanks, sir.
Senator Blunt.
Thank you, Mr. Chairman. Dr. Dobbs, I assume that you're able to draw these conclusions about the activities that people have engaged in these outbreaks, which I assume is based on a contract tracing program. Can you tell us where that stands, and if you have in place what you need for the rest of the year to have a robust contact tracing program in the state?
So we've been fortunate in that we never stopped doing contact tracing. We had 100% commitment from the beginning. So we are running about 95% completion on a daily basis. Some of those are stragglers who we have trouble getting a hold of, but most of them are new cases we haven't been able to track down. We have an average notification to contact tracing of 1.5 days for every new case. Certainly want to be faster, but it's not too bad. Going forward, though, what we've done is, though, we've basically sort of rated the piggy bank to bring these teams together. So we have TB nurses, or HIV nurses, or our immunization nurses, our epidemiologists. We have them just all pulled together, and so we're starting to transition to hiring new people. We have federal money to hire those folks, and so that's going to be our challenge, is bringing them on board, especially at the physical year transition. You know how that stuff works, but we're trying to get that pushed through really quickly to hire nurses, epidemiologists, and specialists, and then beyond that, we have surge capacity where we're going to fund and train all the county health department personnel so that they can do the local investigations, and then they can be surge capacity too. And if we include all those people, and then have in reserves not only those people but the TB and the HIV folks, we feel good, at least on that part of the plan. If we can staff up, we should be able to maintain. Thanks, sir.
Did I overlook anyone? Senator Horn.
Thank you, Mr. Chairman. Dr. Dobbs, again, we appreciate your service. Senator Fillingane mentioned the disparity of this disease affecting the African American community at a higher rate than population would seem to indicate. And you mentioned social issues, but what I've heard all the experts say is that that is a problem, but the underlying health morbidity issues that are prevalent in the black community more so than in the majority community are a big factor as well. And at one time, I thought we were going to be doing massive testing of folks who were not symptomatic, but we don't see, I don't see that we're doing as much testing as I thought we would have been doing at this point. So could you speak to that? And also, could you speak to this idea of these long-term disparities, long-standing disparities, and what kinds of thought processes the department is going through on how, as we try to recover from this pandemic, we address, these long-standing disparities in some organized fashion?
Now, those are fantastic questions. The testing question, it's really a tricky one. In the natural sort of psyche, testing has become almost like it's a treatment. And there's a thought that if you test everybody, it's going to be okay. Testing is good for today only. And if we tested 3 million Mississippians today, it would mean we'd find the people today. But all those people who have the cicada bugs hiding under the surface are just waiting to come up, are going to pop up tomorrow and then for the next 10 days. So it's a real challenge to use that as a control strategy broadly. Now, what we've done and what we've recommended is testing for symptoms or people who are worried about having been exposed. So, if you live in Wayne County and you went to a party and you think you might be exposed, come in and get tested. If you've been in your house 2 weeks by yourself and have DoorDash deliver everything, probably not DoorDash in Wayne County, but you probably don't need to be tested. So there's going to be a hierarchy of risk. We have ramped up testing, but we actually have diverted a lot of our effort into this nursing home situation where we tested, almost 30,000 people in 2 weeks, in addition to what we normally do on a daily basis. So the targeted probably is going to be a good idea, but just know, and for your constituents, if they think they could have been exposed, have them come get tested. And wherever we are, we're happy to do it from that perspective. On the disparities issue, it's obviously enormous. It's what drives Mississippi's bad health outcomes. There's no doubt about it. And if we don't address that, then we're always going to be at the bottom of the heap. If we look at for COVID specifically, if you look at what people die from COVID, it's the coronavirus, but it's the people who have diabetes. Diabetes is the worst piece. It makes your body unable to tolerate that kind of insult. And hypertension and cardiovascular disease are really huge. And so that's one of the reasons why it's so bad in not only the African American community, but the mortality rate is by far the highest in Native Americans in Mississippi. And so that's also correlated with the high rate of diabetes and hypertension. As far as addressing the long-standing disparities, I think a lot of that's in y'all's court. But we'll do everything we can. We have a preventive health office that we're trying to build out, a health equity office. We got a part of Jackson Heart study anything that we can do to kind of make sure people have access to healthcare, prevention, understanding of how you do it, access to exercise, healthy food, you know, and then good education and a good job is the best public health you could ever have.
And is there money in your budget or from CDC or elsewhere that will allow you to address these long-standing issues?
We have a modest amount of funding for that. It's not huge, but it's enough to maintain an office of about, you know, 50 folks, something like that. So, you know, I would say we're underinvested overall. There may be more than that if we consider the tobacco and other money we're using.
Thank you, Dr. Dobbs. Thank you, Mr. Chairman.
Thank you, sir.
Anyone else? If not, thank you very much, Dr. Dobbs. We appreciate you coming over to visit with us. I appreciate the work of the committee. If there's a motion to rise and report, I would entertain such a motion. I hear a motion from all sorts of areas.
Sir,
all in favor, aye. Opposed, no.
Thank you.
Thank you.